Hi everybody, first of all, thank you for attending this webinar. Today we'll be focusing on clinical auditory evoked potential, or AEPs. As you attend this webinar, I just want to let you know that all our recordings and our other webinars are available on our clinical website, which address you can see on the bottom of this slide. Those webinars are provided by the clinical application team, which are employees that are focused in specific modalities. We have one team for EMG-IOM, one for EEG-ICU, one for sleep, and all of us are creating those documents for your training and information. About myself, my name is Antonine Mulot. I'm application specialist at Natus. Entered the company in 2011 on the field for our French office, was dedicated to EEG, EMG and IOM, and joined the international team last year to cover fully EMG and IOM in the EMEA region. So let's go to the AEPs. When we discuss AEPs, I want first of all to give you a few definitions or terminology that we are using for those specific protocols. First of all, what is an auditory evoked potential? The auditory evoked potential is the recording of cortex activity induced by an auditory stimulation. Because of that, there are several groups of auditory evoked potential that we can define. The early responses, the middle latency responses, and the late responses. Those three groups will apply to different tests. So the early responses are responses from the cortex below 10 milliseconds. Those early responses correspond to testings such as ABR or BERA. The middle latency responses are responses that are between 10 milliseconds and 50 milliseconds, which are not that much used in clinical use. And finally, we have the late responses, which are responses from the cortex beyond 50 milliseconds. Basically, those are responses that are assessing the patient attention, for example. Some of the tests that may be used for those late responses are called P300 or MMN for mismatch negativity. Because we record evoked potential, which are tiny potentials, what we need to talk about is averaging. Averaging allows to extract a potential that is buried in some activity, which can be EEG or muscle activity. The evoked potential that we are recording are so tiny and recorded from the brain that they're actually buried completely in EEG activity from the patient. So therefore, we average the signal to create a mean waveform that will really single out the responses to the auditory stimulation. So as you can see on the right side, the idea is to record the direct signal for each stimulus and then create consecutive averaged groups so that in the end we can extract the pure stimulus reaction, and then amplifying the signal we actually get a waveform that will be reproducible corresponding to the response to that specific stimulus. The EEG signal in that case is handled kind of like a noise, which would be random, and if we average it over time, shall cancel. Talking about stimulus, we need to define a few terms about stimulus polarity. There are three polarities that are used in auditory stimulations: condensations, rarefaction, and alternation. Condensation is applying a positive pressure on the ear thanks to a headset or tube inserts. Rarefaction is the opposite. We apply a negative pressure on the tympanum. And alternation is a mix between condensation and rarefaction. In that case, we do one-time condensation, one-time rarefaction, and those stimuli will be interleaved. This method is quite useful because whenever we stimulate a patient, there is a stimulus artifact. The condensation will give a stimulus artifact in one direction, rarefaction in the other direction. So alternation theoretically will cancel that stimulus artifact. Finally, the last term that we need to define are the stimulus pattern. There are three major groups of patterns that are used in auditory evoked potential: clicks, peeps, and bursts. A click is a monophasic square shape of a specific duration that will basically assess a large hearing range of a patient, and that's basically what we use in BERA or for short latency responses. Peeps are kind of a click with a specific frequency that allows to assess the hearing capability of a patient at a specific range. And different envelopes may be used to better extract the response from the patient. Tone bursts are stimulations that are mainly used in late responses. So those are the three groups that we may hear of. Now let's focus on early responses. The early responses are testings that are called ABR or BEP, BAER. There are several names for it. The ACNS has released guidelines on those tests, and that's what I want to share with you now. So the ABR or BAER are two terms for those short latency responses. ABR stands for Auditory Brainstem Response. BAER stands for Brainstem Auditory Evoked Response, but they all apply to the same kind of test. The goal of this test is to evaluate the integrity of the 8th cranial nerve at several levels, so from the peripheral nerve to the cortex, on a broad range of hearing frequencies. So this test is basically used to assess the integrity of this nerve from 2 kHz to 4 kHz hearing range of a patient. On the below part of this slide, you can see the shape of the response that we can record using this test. And there are 7 peaks that are defined, which all will give information about the transmission of the information from the auditory nerve, which is the first peak, up to the auditory cortex, which is the waveform number 7. For the stimulus, the ACNS recommends the use of clicks with a duration of 100 microseconds for adults. They give absolutely no recommendation about the type of stimulus that should be used, for example, rarefaction, condensation. However, what they say is that the use of alternation may give poorer resolution of the responses for specific pathologies. At the same time, it is still a nice pattern we can use because it reduces the stimulus artifact in some cases. By all means, the stimulus should be applied monoraly, so only the left ear, then only the right ear. No bilateral stimulation. The repetition rate can be applied from 8 to 200 Hertz. The best repetition rate, however, would be between 8 and 10 Hertz. If we stimulate above 10 Hertz, the amplitude of the responses may decrease. Regarding intensity, the ACNS recommends to stimulate between 115 and 120 decibels SPL and apply a masking noise such as white noise on the contralateral ear of 60 dB below the stimulus intensity. The use of masking allows to avoid responses that might be conducted through the bone. So masking will be really helpful to get proper responses. Other stimuli, such as PEEPs, may be applied if we want to go for frequency-specific testing. So, for example, to test a patient response to 2000 Hertz noise or 500 Hertz noise, which is a test that can also be done in audiology. In that case, for example, they say we can use PEEPs with a Blackman envelope. For the recordings, the ACNS recommends the use of 4 electrodes. Recording electrodes on CZ, A1 and A2, which are the 2 earlobes. If applying the electrodes on the earlobes is too painful, then mastoids may be used as an alternative. In some cases, in centers, people have been using FZ instead of CZ. The ACNS does not recommend to use this montage because the amplitude of the responses may be reduced. The ground should be placed on FZ, or in children can be also placed on the shoulder. However, it's important to not place the electrode next to the deltoid in order to avoid ECG artifact. No matter where we place the electrodes, the impedance should be absolutely kept very low, so below 5 kilo ohms. Regarding the channels that are recorded, we will record CZ and the earlobe on the ipsilateral side and CZ and the earlobe on the contralateral side for the responses. The recording length should be at minimum 15 milliseconds so that we can see even delayed responses. I've read in some other papers that for children, for example, it's even better to use 25 to 30 milliseconds to really make sure that we can record all the waves, all the markers for the auditory stimulation. The signal should be filtered between 10 Hertz and 3 kilohertz. However, what can happen, especially in this kind of very sensitive testings, is that you would have artifacts from EMG activity or noise issues from electrical systems. In that case, the ACNS says that we can change the filters from 100 to 3 kilohertz. That would reduce especially the electrical noise. However, it's best to keep the range as broad as possible. As we discussed before, for evoked potentials, we average the signals. We can average the signals between 1,000 and 4,000 times. Of course, the lower the better because the test will be shorter. However, we should not stop the testing below 1,000 averages. The ACNS does not provide any recommendation in terms of supply use. And in terms of patient condition, this test can be applied whether the patient is awake, asleep, or sedated. So if there is a very difficult patient or children, sedation may be used. Regarding the results, we need to mark at least the 5 first waves. And what the ACNS recommends is to mark and read the latency for the peak number 1, 3, 5, the difference of latency between the peak 1 and 3, 3 and 5, and 1 and 5. Normally the peak number 3 should be in the middle, so between the peak 1 and peak 5, so the latency difference between 1, 3, 3, 5 should be the same. and half of the latency difference between 1 and 5. We shall also mark the amplitude of the waveform of the wave number 1 and 5 and calculate the amplitude ratio between peak 4, 5 and 1. So those are the guidelines. Now, how can we actually make this test in real life? So let's talk about the clinical workflow and how we analyze the data. Before we even think about performing the test, we need to prepare the patient. So how does it go? In terms of accessories, you can see on the right side of the screen the different alternatives you have. You may use subdermal needles, which are disposable, or cup electrodes to paste on the cortex. If you use scalp electrodes, so the cup electrodes, you need to have 2 pastes with you. The new prep to prepare the skin and the 1020 to actually fix and ensure good contact of your electrode. I do not have any preference between cup electrodes and the subdermal needles. All I can say is that if you use subdermal needles, it is invasive. At the same time, you can easily ensure a low impedance of the electrodes throughout the study. For the stimulators, we can use 2 types of stimulators, headsets or tubal inserts. Headset would be mostly used in clinical labs. Tubal inserts would be more for neonates and so on. However, all headsets have a color coding. There is 1 ear blue and 1 ear red. Red is for the right ear, blue is for the left ear. When the patient comes in, he should be sitting comfortably in a chair or lying down to make sure he is fully relaxed. If possible, the patient should avoid moisturizer or hair gel on the day of the exam. If he comes in and he has this kind of products on, you may dissolve, for example, the hair gel with alcohol pads. So just put a little bit of alcohol pad on the location of the electrodes, leave it on while you prepare your cup electrodes or your needles, and this may dissolve the product. Then to ensure a proper positioning of the electrodes, we need first to prepare the skin. So the use of new prep will allow to remove fats that are on the skin and ensure a proper conductivity of the signal. Then if we use the subdermal needles, we can just place them directly. And if we use cup electrodes, then we need to fix them using the 1020. So we don't need too much paste on the cup, just place a little bit and then press hard until the paste comes out of the hole in the middle of the electrode, and protect that with a little bit of gas. All cables, they should end up in a ponytail style so that we can reduce the noise pickup. And also, if the patient has to move, then you have minimal risk of electrode removal. The impedance, once we have applied all electrodes, should be below 5 kilo ohms. If in some cases you just cannot go up to that level, try to keep the impedance as balanced as possible between all electrodes. What I mean is, if you have one electrode at 5 kilo ohms and the other one at 50, that would be worse than having the 2 electrodes at 15 kilo ohms. Having balanced impedance throughout all the electrodes would allow you to have a more stable baseline. So best case scenario, you go below 5, which is very easy with the subdermal needles. If you cannot go down to that level, then just try to keep them balanced. So when we stick the electrodes, we stick the electrodes on CZ, which will be the active electrode for our montage, the two earlobes, A1, A2, which will be the references, and the ground on FZ. If you go for the method where you fix the electrodes instead of the earlobes to the mastoids, be careful about the placement, because if you place them too low, you may pick up some ECG artifact. Then we put the headset on the patient with the right collar on the right side of the patient, the left collar on the left side of the patient. Duration of stimulus, we said, was 100 microseconds for adult patients. For infants, we actually apply 50 microseconds. So once this is all done, we can properly do the testing. So we place the electrodes, check the impedances, place the headset. In a clinical practice, what I personally like to do is first look for the patient hearing level if the patient is cooperative. So basically we would start the stimulation, increase it, and ask the patient to tell us when he can actually hear the sound. It should be normally around 35 decibels SPL. Once this is done, we add up to 60 decibels to that value and then start averaging. I like to wait a little bit before I start averaging to allow the patient to get used to the sound, relax, and then we can start the recording. And then we would get the waveforms that you can see on the right side of the screen. On the upper channel, you can see the ipsilateral response, and below the contralateral response. And we will mark the waves from 1 to 7. The most important ones that you need to see is the number 1, the number 3, and the number 5. The contralateral channel will help you because you can see the wave 5 on it. However, this wave 5 should have a longer latency than the wave 5 on your ipsilateral channel. So that contralateral channel helps you to mark your waves on the first line. For each ear, we need to perform at least 2 runs just to make sure that the response is reproducible. So overall, the test will take around 30 minutes. What I describe right here is a test with a cooperative patient. If the patient cannot cooperate, just go for the ACNS guideline, apply between 110 and 120 decibels SPL, and then start averaging. You will get roughly the same responses. In terms of results, we will mark the latencies for number 135, latency difference between 13, 35, 15, the amplitudes for the wave number 1 and 5. The amplitude ratio, in my experience, I haven't seen it so much applied. However, what is also important to assess is how reproducible the waveforms are, and if we see any asymmetry between the responses from the left stimulation and the right stimulation. Below, I provide you some normative values we had for the testing. So it's important, if you use normative values, to make sure that your type of stimulation is the same exactly as the type of stimulation that they apply. So make sure that you use the same frequency rate, make sure that you use the same type of stimulus intensity, make sure that you apply the same stimulus duration. And then you can use those reference electrodes, those reference values, pardon. On a general note regarding the stimulus polarity, different stimulus polarity can change a little bit the shape of your waveforms. For example, rarefaction is known to enlarge the wave 1. The alternation will not enlarge this wave 1. However, as I said, it can have a poorer resolution in some specific pathologies. However, it can be very nice to reduce what we call the microphonic cochlear artifact, which is this ringing artifact that you can see on this waveform on the right side of the slide. So that's how we would perform a patient for ABR. Now there is a second testing that exists for short latencies responses, which is called the objective hearing threshold, or OHL testing. This test is used for auditory screening. Basically, it will be a series of stimulation at different intensities, and then we will see if the patient has a wave 5 at these different stimulations or not. So basically this serves as an indicator of the auditory threshold without needing the patient cooperation. For that test, we use what we call the dBOHL, which is the decibels that ENTs and audiologists use. Just so you know, the decibel OHL corresponds to roughly 30 decibels SPLs. For this specific test, we use a filtered click, or what we call a PEEP, of 1000 Hertz with rarefaction, duration 100 milliseconds, and a stimulus rate around 13 Hertz. The electrode placing is exactly the same as the previous test. Just like the previous test, this testing has to be applied on each ear. And then we apply the stimulation at different stimulus level. So we start at a high level, 90 decibels OHL, so 90 decibels above an average hearing threshold for patient. And then we do different waveforms with steps of 10 or 20 decibels down. So basically we could do a patient with stimulations at 90 decibels, 70 decibels, 50 decibels, 30 decibels. And for each of these intensities, we will mark if we see a wave 5 on the waveform. When the wave 5 disappears, then we know that we are below the hearing threshold. To get proper responses for this testing, we need to make at least 2 averages for the highest stimulus and the threshold stimulus. So in the example on the right side, we would do at least 2 averages for the stimulation at 80 dB, then we go down to 60, 40, and then for 20, we need to do 2 averages as well. Of course, if you have the time, it's best to make 2 averages for every stimulus intensity, but if you're in a hurry, at least you need to make 2 averages for the highest stimulation, 2 averages for the lowest stimulations. In terms of the results, I've seen guidelines asking to mark the latency of the marker 135, and again this difference of latencies between peak 1335 and 15. In clinical practice, I've only seen the marker 5 being assessed. However, what we need to also mark for the reporting is the BERA threshold. So this is a number in decibels, which will provide us the hearing threshold of the patient. This threshold is the midpoint between the intensity where the wave 5 was detected and the intensity where it has disappeared. So if at 20 decibels you had no wave 5 and 40 you had one, your BEP threshold will be 30. For your information, when the stimulus decreases, the latencies of your waves will shift. So for example, for wave 5, it will shift of roughly 0.03 milliseconds per decibels. However, the interpeak latency will remain constant at different intensities. As you can see on the right side of the screen, there is a graph that has been done out of 7 patients that were normal. The thick lines are the latencies at different stimulus intensity, and the dotted lines are the interpeak latencies. And as we can see, the latencies of peak 135 really go down, where the interpeak latencies remain constant. I want to talk shortly about late responses. Late responses, one of the most known tests is called the P300. This is a test that is used to assess patients' attention, and it may be applied in ICU to assess the evolution of the coma and chances of awakening of the patient. The electrode setup is the same as for the short latency testings that we have just discussed. However, the stimulation is different. In this case, we provide 2 sounds. One is called standard, one is called oddball. And we will do average responses for the standard stimulation and the oddball and look at how different the waveforms are. On the oddball waveform, we will mark 2 peaks called N1 and P3. So N1 is around 150 milliseconds, P3 would be around 300, but it changes with the patient's condition. However, just knowing that we have those waveforms, so those markers, N1 and P3, can allow to evaluate the degree of chances that the patient will wake up. This test has another alternative that is called MMN, mismatch negativity. If you are interested in that particular application, we have a clinical note on the website that actually provides you all information on the workflow for this specific technique. So finally, I want to discuss about what goes wrong when we perform AEPs, because in those presentations we always show how the waveforms should be and so on. However, in real life we may have issues sometimes. So let's talk about the pitfalls. What can happen sometimes is that you find your responses to be too low. The amplitudes are too low when you start your AEPs. That may be due to the stimulation frequency. If the stimulation frequency is too high, the amplitudes will reduce. So in that case, it's best to keep the stimulus frequency below 10. So 10 is okay, but it's best to keep it below 10, not go up to 30. Sometimes we can get a very unclear response or a lot of rejection from our waveforms. That can be due to the stimulus intensity. If the stimulus intensity is too high, it will discomfort the patient. So he will contract, you will have a lot of EMG artifact, and this will not only have an effect on the quality of the waveforms, but also on the level of rejection that you will experience. So the test will take longer, and the quality of the waveforms will not be good. In some cases, you could see unstable baseline, you could see noise artifact, you could see a lot of rejection. That may be due to electrode impedance. If the electrode impedance is too high, you will pick up more noise, and therefore a bad quality of your waveforms. So keep the impedance below 5 kilo ohms, or try to have it balanced throughout all electrodes. Sometimes what we can experience is to have a waveform where the peak number 1 to 5 show up correctly, but after that we have a very high amplitude response that kind of pollutes the recording. This is muscle artifact from a contraction of the jaw or the neck. It's called the post-auricular muscle artifact, and it appears around 10-14 milliseconds. So this is purely due to the patient position and the use of mastoids for the reference electrodes. So in that case, first of all, check the patient position, make sure he's comfortable, and if it does not go better, just use the earlobes for the reference electrodes instead of mastoids. Also, for the comfort of the patient, we shall make sure that there is not too much noise in the room. Another thing that happens, and that I experience quite regularly, is the confusion that there can be between decibels SPL and decibels OHL. Basically, this happens when I hear somebody telling me, I'm stimulating at that intensity, but the sound, I perceive it as low compared to what I know. So this may be if we make a confusion between applying 90 dBs SPL or 90 dBs OHL. So the decibels SPL are decibels for sound pressure level, which is a term that is mostly used in urology. A 0 decibel SPL means zero pressure applied to the ear. In audiology, however, the audiologists use decibels OHL, so objective hearing level. This means that 0 decibel OHL mean at this intensity I don't hear, but at 1 decibel I start hearing a sound. So there is a shift between dB SPL and dB OHL, and that shift is roughly 30 decibels. So 90 dBs SPL for a neurologist, they correspond to 60 dB OHL that the audiologist use. And your EMG system should be able to perform the stimulus in SPL style or OHL style, so that you can apply your method. Finally, there is a last term that may be used that you might hear of, is decibel SL, which is sensation level or auditory threshold. So that is also a term you may see on your systems, but that's purely the assessment of the auditory threshold of a cooperative patient. What you can also experience is ringing of the waveform at the beginning of your recording, such as is shown on the picture on the right side of the screen. This is called the microphonic cochlear artifact. This is absolutely normal. It can appear mostly when you use rarefaction or condensation as a stimulus. If you want to get rid of this, just change your stimulus to alternation mode. In that case, the ringing will be one time up, one time down, and when we average, it will just cancel. Finally, let's talk about the noise artifact. The other instruments that are in the room can have an effect on your recording, and what you would see is 50 or 60 hertz noise on your signal, and it's extremely painful when you are performing AEPs. So if you experience noise on your waveforms, here's what you need to do. The first thing is to check the ground electrode. Make sure it has a low impedance. Maybe change it for an electrode that has a larger surface of recording. To reduce the pickup of the noise, you can braid your electrodes. If your cables are not together, so the recording cables, if they go in every direction, every cable will see a different type of noise and it will damage the quality of your recording. So braid them together and this will reduce the noise. If that doesn't work, unplug all unnecessary power supplied systems in the room, so unused computers, laptop chargers, the chair of the bed or the bed. And finally, also fluorescent lights may have an effect. So turn off fluorescent lights if that's the kind of light that you have in your laboratory. Hopefully with all these tricks you will be able to make some good recordings with the AEPs. Thank you for your attention. If you want to download this webinar, just register on our website. You will have access to all this presentation, the videos, and also register for upcoming events. If you have any questions, contact me on my email that is displayed here. I'll be happy to help. Thank you very much.